Understanding Medicine.
I am Professor Aziz Rehman, and today we're going to talk about a very common condition called irritable bowel syndrome. It is presumably fairly common. About 20% of the adult population may be suffering from this condition, and irrespective of gender or race or ethnicity or social status, people have this condition, and it's a diagnosis of exclusion. In basic introduction, it is characterized by certain symptoms, and you need to have those symptoms for fairly long duration and without having any evidence of any organicity. That means there is no evidence of any physical component to this condition, no tumor, no infection, no autoimmunity, so nothing of that sort. So we need to actually first rule out any other condition which can cause similar symptoms, and then you have to apply certain criteria called Rome criteria. So fairly big population is suffering from this condition, and it's very problematic. It causes a lot of symptoms, and it affects your quality of life, both physical and mental. But it usually does not have significant morbidity or mortality because it doesn't kill or doesn't cause any serious problem. But the psychological component is very, very significant. Many people, they are very troubled and their quality of life is very compromised because of this condition. It's a functional gastrointestinal disorder. What is that? What does that mean? Because any abnormality could be anatomical, like peptic ulcer, like intestinal obstruction, like hiatus hernia, or it could be functional gut disorder. That means there is problem with the movement and the secretion of the gut, but no physical cause, no anatomical abnormality, including histological. There isn't any, no microbiological problem. So this is the definition, and there are many functional gastrointestinal disorders like functional dyspepsia. So this is one of them. Symptoms, the cardinal symptom or the most important symptom which is actually required for the diagnosis is abdominal pain. Now, according to the new criteria, it has to be abdominal pain, not just fullness or not just little discomfort or bloating. It has to be actual abdominal pain, and this pain is typically situated in the lower part of the abdomen, and it comes and goes with associated other symptoms, but pain is the main symptom which is actually relieved to at least some extent after defecation. That I will discuss in criteria, but here just abdominal pain, and this pain should not have any characteristic of any other known condition. Like biliary colic has a specific pattern, urinary colic has a specific pattern, menorrhagia pain has a specific pattern, and dyspepsia, ulcer disease has a specific pattern. So this abdominal pain should not follow any of those patterns, and it is located in the lower abdomen, and it comes and goes at least the frequency of once every week and at least for the last 3 months. Bloating is associated with pain. Bloating is sense of fullness. People feel as if their abdomen is distended, like there's a lot of air in them, and that they have this feeling, and they feel slightly better when they belch out some air or when they pass it as a flatus. Diarrhea is a very common symptom. In fact, there are various types of IBS. In diarrhea, predominant diarrhea is present. Diarrhea is usually not watery, and it is also usually not profuse. Profuse watery diarrhea is a feature of some infections. So it is like 3 or 4 times per day, and usually stool is passed during the day, mostly in the morning. From the morning till afternoon, patient passes 2-3 times, and then the afternoon the frequency is reduced, and at night usually patient does not wake up because of the diarrhea, and it is not very watery. And some people, they have constipation. Now constipation could actually mean that patient passes stool less frequently and passes hard stool, but many times patient describes it as constipation, but when you ask the detail, patient says he passes or she passes stool 2 or 3 times a day actually. But since patient does not get that feeling of satisfaction after passing stool, patient describes it as constipation. So you need to actually go into the details of history to be able to find out what exactly patient means by constipation. In some patient there would be alternating diarrhea and constipation. And the last one, I think requirement is no red flag symptom. Red flag symptoms mean some symptom which potentially indicate some serious problem like bleeding per rectum. Now, but I think I'd like to explain here one thing, that there could be something which can be called as a red flag symptom, but due to some coincidental disease. For example, if somebody has hemorrhoids, piles, that is a common condition, that person could have IBS also. And if that patient complains of bleeding per rectum, and if you can judge that this bleeding per rectum is due to piles, then that would not be counted as a red flag symptom when we evaluate IBS. Similarly, weight loss, there could be other causes, fever could be other causes. So if you have any such symptom which can be linked to the GIT symptom, then IBS diagnosis should not be considered as a primary diagnosis. Then other gut related disorder like inflammatory bowel disease, some chronic infection, diverticulosis, celiac disease, and many other conditions, they should be considered. In fact, we always need to rule out all these conditions before we entertain the diagnosis of IBS. There are subtypes. I just already mentioned IBS, which is diarrhea predominant, and this in my belief is the commonest type. 80% would have this type, and then some have constipation, and these are actually may represent different phases. There could be a phase of diarrhea, there could be a phase of constipation, so that means the mixed variety. So all of them have to fulfill the criteria, the same abdominal pain, lower abdominal pain which comes and goes and which does not follow any other pattern, and there should be no evidence of any other organic disease. The causes, as I said earlier, we do not know for sure the cause. What we know with reasonable certainty is that there is no infection, there is no autoimmunity, there is no malignancy. So it is basically considered to be a psychological or psychosomatic disorder. So there is a problem with gut-brain axis. Now this is a very interesting concept. It's mostly theoretical, but we know that there are many bacteria in our gut which are unique to ourselves, and these bacteria, they produce many active substances like gamma aminobutyric acid, like small chain fatty acid, and many other things which can be absorbed, and once they're absorbed they go to the brain through circulation, and they can actually affect your thought process, your emotional state, your food preferences, your appetite, and many other things. And then brain produces many signals, mostly through vagus nerve and other patterns through pituitary. They can affect our gut secretion and gut motility. So it is theorized that there is a problem with gut-brain axis. So there could be dysfunction that is an inherent feature of IBS. But it is hard to tell, is it the abnormality of microbiota dysbiosis which is responsible for these mental changes, or the problem is primarily psychological, which changes gut motility and alter our microbiota. But there is evidence that a specific pattern of microbiota is associated with IBS. Visceral hyperresponsiveness. Now, every viscera has got certain responsiveness, pain sensitivity. If abdomen is distended, if stomach is distended, there would be some discomfort. But in IBS, this responsiveness, this sensitivity is increased with the same amount of distension of gut, which is a part of our digestive process, because gas is formed as a part of normal digestion. So if there is increased responsiveness, the same amount of air in the stomach or the colon would cause more pain. And this has been proven by experiments. If you passed a catheter and inflate a balloon in a normal person and in a person with IBS, the person with IBS would feel more discomfort with the same amount of pressure in the balloon. So there is increased responsiveness. This is perhaps because of, again, dysbiosis, and maybe there is very mild microscopic inflammation in the gut wall also. Food sensitivities. This is very important. There are some specific foods which varies from person to person, which precipitate these symptoms. And these foods are typically those which are FODMAP diets, which I'll explain in one of the slides. What are the FODMAP diets? So they increase your symptoms of IBS. So I think many patients would describe some foods are otherwise considered very healthy, very safe, very mild, but patient would describe very explicitly that that food precipitates or triggers their symptoms. So these are some of the causes or some of the contributing factors in the pathogenesis of IBS. Stress, of course, is very common. Again, it is hard to tell if stress is the primary problem and that causes symptom of IBS, or IBS symptoms, they lead to poor quality of life and stress. So, but there is a vicious cycle. Stress is definitely a known factor. People describe that the symptoms they increase during stressful phases of their life. How do we make a diagnosis? I have already described it as that this is a functional disorder. The first thing is by detailed history, detailed physical examination and laboratory tests, we need to rule out any other condition which can cause similar symptom. We cannot afford to miss a physical illness because that could lead to some serious consequences. So I think we must do our best to rule out any physical condition. That is also why the criteria require that it has to be for several months, 3 + 3, 6 months symptoms, only then we can make a diagnosis. So this is basically to rule out other condition just by the time. But if required, you will do any test which may be relevant to rule out all other conditions. Of course, there are some symptoms in a typical patient. Even without ruling out, the symptom would suggest that this is IBS. But I think you need to rule out all other known conditions. Then we apply Rome criteria. There are a series of criteria. The latest one is Rome 4 criteria. So we apply these criteria. If we make a diagnosis according to the criteria, then the diagnosis is more definitive and more reliable, and I think the chances are that you have ruled out other conditions. So I think whenever possible, apply these criteria. But there would be cases. Now I must admit one thing, that there are cases who at a certain stage of their disease, they do not fulfill the criteria, but they still have this condition. So an experienced physician can still make a tentative diagnosis of IBS and treat it as such. But I think you need to actually fulfill the criteria to formally label it as a case of IBS. So what are these criteria? First, recurrent abdominal pain. I have already described this, a typical distension like pain, mild to moderate, usually not very severe, a lower part of the abdomen, and it is usually relieved or at least minimized after defecation. So the abdominal pain must be present on an average at least 1 day per week. Could be more, but at least 1 day per week. in the last 3 months. Okay, and the pain should be associated with at least two of the following criteria. One, related to defecation. That means pain improves after bowel movement. And change in stool frequency. The pain is associated with a change in how often you have a bowel movement. But remember, we have a constipation variant also. So in that there may be actually reduced frequency. So any change in the frequency of one's bowel movement, that is to be counted as one of the criteria. Then change in stool form or appearance or consistency. The pain is associated with change in the form of appearance of the stool. Usually there is presence of some mucus or there could be mucoria. So abdominal pain with any two of the three criteria, with no symptom, red flag symptom, and no evidence of any other disease. Now this is what I mean 3+3. Symptoms for the last 3 months, and once you label the patient tentatively, then further 3 months the symptoms do not subside. So actually you need to have symptoms which I've described in the earlier slide for 6 months. This is basically to rule out other conditions which may remit during this period. So I think the symptoms are typically chronic. But of course, there would be cases who do not have 6 month duration, but at that time you cannot make a definite diagnosis. If you follow them up, only then you will be able to make a formal diagnosis. So the criteria should have been met for at least 3 months, with symptoms starting at least 6 months before the diagnosis. So these criteria should not be explained by another medical condition. Okay, so this is all about the criteria. So I think essentially chronic abdominal pain with some change in the frequency of defecation, some change in the stool consistency, and no other symptom, and which is very, very chronic, that is the requirement for the diagnosis of IBS. Other tests, they are done. There is no test to confirm IBS. Yes, you're right. There is no test to confirm IBS, but we need to do some tests to rule out other conditions like CBC, LFTs, RFTs, and IgA-TTG. Now CBC, LFTs, RFTs would rule out other coincidental conditions. TTG will rule out celiac disease. Stool complete examination to rule out chronic infection, amoebiasis, giardiasis, and other less common infection. Calprotectin. Now this is a protein which is produced by neutrophils, and if somebody's gut is infiltrated with neutrophils, and that will happen only when there is some inflammation, like an inflammatory bowel disease. So stool for calprotectin would be positive, and it will also be positive in all other gut infection. This test is done typically in chronic diarrhea when we are stuck with the differential diagnosis of IBS versus IBD. Presence of calprotectin would favor IBD, and then that patient would require further tests, typically colonoscopy with biopsy. H. pylori antigen, Clostridium difficile toxin assays should also be done in chronic conditions. Abdominal ultrasound is very, very useful test, very simple, non-invasive test. I think every patient with chronic GIT symptom should have abdominal ultrasound before we consider endoscopy, because this is actually a very mild test. There are conditions like chronic cholelithiasis, cholecystitis, chronic pancreatitis, diverticulosis, and pelvic inflammatory disease. These are conditions which can mimic the symptoms of IBS, and they can be easily ruled out on ultrasound. Tuberculosis, Crohn's disease, there could be some signs on ultrasound. Then lower gastrointestinal endoscopy. This is the most definitive test to rule out other chronic pathology. So I think This is done at the last, although this is the most definitive, but this requires you need to have a, this is not a very easy test to undergo. It's slightly painful, maybe at least unpleasant, and maybe expensive, and it's done only in limited facilities, and that is typically done at the end. No patient would want endoscopy as a first choice, so only after you have gone through all these tests, and then you will consider gastrointestinal endoscopy, especially if there is something to suggest the organic disease. Otherwise, if you have all these tests negative and patient is reluctant to undergo lower gastrointestinal endoscopy, I think it would be fair to give a trial of IBS treatment. Triggers, some factors which can trigger IBS symptoms, certain foods, and I'll give you the list, and these foods may vary from person to person. Stress is a known trigger factor, hormonal changes. Now in women, we have seen that during periods, there are various parts of menstrual cycle, they have symptoms aggravation. There are some foods which can trigger the symptoms. Certain foods by the process of fermentation, there are certain foods which are not digested in the intestine, the small intestine. They pass as such to the colon, and in the colon, our bacteria, they ferment it. As a result of that, there is gas formation, and there is formation of certain other substances which can precipitate or trigger these symptoms. And they may also have osmotic effect, like because food goes to the colon undigested, and that may be soluble, and that may suck some fluid into the gut, and that may cause symptom, and that would make the stool consistency as softer and liquidish. Then rapid absorption of certain things, and lactose intolerance. If food passes to the, for example, lactose, somebody has lactose intolerance, not clinically known, there may be mild lactose intolerance that may pass to the colon, pass through the small intestine to the colon without getting digested, and in the large gut it may be cause irritation and precipitate symptom. And stress and hormonal changes are known. In women, we have seen that during various phases of menstrual cycle, they may have their symptoms aggravated. Now, what is the treatment plan? In these diets, we suspect a diet, and first we eliminate for a specific period. So suppose we suspect wheat as a culprit factor. So we ask the patient to avoid all wheat products for say 2-3 months and see if there is any improvement. And then we, in the observation period, if there is clear-cut improvement, and then we reintroduce the food. So if the symptoms come again, that would, I think, for sure tell you that this food is responsible, and then patient is instructed to avoid this food for long-term basis as much as possible. So lifestyle changes are important. In lifestyle changes, avoiding stress is important, and following a certain food plan, avoiding those food which cause symptoms, they should be I think encouraged. And medication may also be done. So these are actually 3 types of treatments: lifestyle changes, dietary modification, and medication. So these are the dietary modification. I like to explain here. I will not be able to go through the whole list, but just basic concept. There are certain foods called FODMAP diet. Now what is FODMAP? These are trigger diets, and this is what is the abbreviation. This FODMAP diet: fermentable, oligosaccharides, disaccharides, and monosaccharides. All 3 are actually carbohydrates, and polyols, which is very similar to carbohydrates. So these foods, these nutrients present in certain foods, they can cause or they can trigger IBS symptoms. IBS symptom may be present all the time, but once somebody consume these FODMAP diets, the symptoms may be aggravated. Now, this is the list of those food which are low in FODMAP, and this is the list of those food which are high in FODMAP. So one can be instructed to take these one and avoid these one. But when you suspect some diet and you want to confirm, I think best way would be to eliminate that particular diet and then observe for some time and then reintroduce. So that is how you will find out if the particular food is responsible for IBS symptom in that particular individual. So this is elimination and reintroduction, which I explained earlier. Fiber generally considered to be a good component of our food, but the fact is that some fibers, because the fiber is also carbohydrate, cellulose, and carbohydrates are not, some fibers are not digested by our gut bacteria, and they pass on into the large gut. The fiber is not digested in the small intestine by our enzymes. So fiber passes as such into the colon, and bacteria can ferment the fiber and cause gas. So it again depends from person to person. Fiber may be responsible. This isabgol, psyllium, so this could be actually responsible. So maybe we can give them some alternate soluble fiber. This is a comprehensive list of FODMAP diet. I think it could be different person, like garlic, onion, wheat, rye, barley, most legumes, certain fruits, apples, pears, cherries, certain vegetables like cauliflower, broccoli, dairy products containing lactose. Almost all dairy products, they have this lactose, high fructose corn syrup, because this is also a carbohydrate, honey and agave nectar, artificial sweetener. So all these things can be potential trigger factors and should be avoided. As a substitute, these are the foods which patient can take. These are low FODMAP foods. So meat, poultry and fish generally has very low FODMAP. Eggs, tofu, lactose-free dairy and hard cheeses. Rice can be taken as a substitute of wheat. Gluten-free grains, certain fruits like strawberries, blueberries, bananas, oranges, they are poor in FODMAPs. Certain vegetables, carrots, and like nuts and seeds are poor in FODMAP diets. Gluten-free bread and maple syrup. So I think every person needs to experiment with these foods and find out which one is the best for that particular individual. But avoidance of food or changing one's food constitute the basic principle of management of IBS. So sometimes avoiding stress, avoiding trigger food may not completely relieve the symptoms. So we have to use certain drugs, antispasmodic. Since one component of IBS, excessive contraction of the large gut, and unlike normal peristaltic wave moves from one end to the other end, usually from proximal to distal, but these contraction waves in IBS, they just contract at one side, doesn't move in a particular direction. So this spasm can be relieved by giving antispasmodic. Since antispasmodic drugs can have some systemic side effects, they could precipitate glaucoma, they could precipitate urinary symptom in elderly men having prostate problem. So we prefer those antispasmodic which has mainly local effect. One example is mebivarin. So those drugs are given which have local effect. Peppermint oil is also effective. There are some special preparations of peppermint oil. Normally if we take peppermint oil, it causes stomach irritation. So special peppermint oil preparations are given which bypass the stomach and or they are released only in the large gut. So that can have antispasmodic effect. So we give the lowest dose, which is enough to relieve symptom, and it could be used intermittently also. So whenever patient has a flare, patient can take medicine. When patient has no flare, symptoms are okay, then patient may stop it. Similarly, laxative in constipation dominant IBS or in the constipation phase of mixed IBS, patient may take laxative. We can give anything which can help relieve the symptoms. Some conventional laxative like this lactulose. Lactulose is a very commonly used laxative and generally recommended because it is non-systemic, but that can actually, because it's a carbohydrate and it goes undigested to the large gut, it can actually theoretically increase symptoms of IBS. So I think some other laxative like Senacort may be used. Anti-diarrheal drugs, but you should be very careful because prolonged use of anti-diarrheal drug could lead to constipation. So I think again, as per symptom, a very short period anti-diarrheal drug can be given. Some patients would not benefit from these lifestyle changes and dietary modification. They would require antidepressants. People do not want to take antidepressant because of the stigma attached with these drugs, but I think they are pretty helpful. Theoretically, you can make a case in favor of tricyclic antidepressants because these drugs, they have anticholinergic effect and they may actually reduce gut motility and they can reduce spasm also. But the same can also lead to some systemic side effects, some unpleasant effects. So from person to person, it varies. Maybe low dose tricyclic antidepressant or modern SSRIs. SSRIs are also effective. Again, we give much smaller dose compared to what we give in morbid depression. So in addition to dietary changes, low dose of tricyclic antidepressant drugs or SSRIs can be given. Paroxetine has been tested and that we know is very effective, but I believe other SSRIs also have beneficial role. Psychological approaches, the people who have lot of psychological component, they might benefit from counseling, from therapies. I think that should be tried because that is without any side effect. Lifestyle modification, patients should be avoided to make life little easy and should avoid stress and should avoid diet. And there are several ways of relieving stress that varies from person to person. For a person who has got religious orientation, I think saying prayers might help, and for others, music or watching movie or company with the friends or going out for holidays, they all help in relieving symptom of IBS. Then one thing which is very much in current research but not yet proven beyond doubts is the use of probiotics. Now probiotics are certain preparations which consist of bacteria, but these bacteria are non-pathogenic. They have some beneficial effect. The purpose is that they restore our normal microbiota. So there are various types like Bifidobacterium infantis can be given. It is usually available in the form of sachet or capsule, can be taken once a day or twice a day. If it is sachet, it can be mixed with food. I think yogurt, and usually they have no taste, so it can be mixed with any food. Lactobacillus plantarum and Saccharomyces boulardii. This is also common. And then we have many combination probiotics. It is not possible, at least for me, to tell which one is the best. Maybe you can try, maybe you can see the literature, and whichever you think you get convinced, that can be used. And they're usually used for fairly long duration, like 1 month, 2 months, 3 months. Sometimes we also use locally acting antibiotics like rifaximin. Rifaximin, it's an antibiotic, and if we use it with probiotics, then the rifaximin will kill the pathogenic bacteria and probiotics will promote our healthy bacteria. So with the combination, maybe there should be some significant relief in symptoms of IBS. But nothing can be predicted. In IBS, what I've seen is that some strategy works very well in some person and the same one in another person doesn't work at all. So you have to find what food and what strategy works for your patient. So since we do not know this disease in full details, further research is going on. We are hoping that there are future development, and we hope that we find out the actual cause and we can fix the problem, because people with IBS, they have a lot of trouble coping with the symptoms. Conclusions: it is a functional disorder, fairly common, can affect both genders, can affect any social status, and typically we have to rule out another known disease, and we have to follow these patients for 6 months to be sure that there is nothing else. So symptoms have to be chronic. Typical symptom is lower abdominal pain, which is relieved with food with defecation to a certain extent, precipitated by some specific foods, and with no red flag symptoms. So hopefully this was useful for you, and I really look forward to see you in my next video. Till then, look after yourself. This is Professor Aziz Rehman from Medurstand-Understanding Medicine.